A 58-year-old client was recently started on warfarin following an atrial fibrillation diagnosis and returns to the clinic for the INR monitoring and dietary teaching. The nurse is reviewing the food the client typically eats. Which food should the nurse instruct the client to keep consistent from week to week to avoid interfering with the medication? Okay, so in cardiovascular system, we talked about कि warfarin has one antidote, that is vitamin K. Okay, now let me give you some information here. When I do have any patient with atrial fibrillation, and if I have to put him on warfarin, okay, so first we'll start with very small dose of warfarin, okay, and I'll ask the patient to come back after a week to have the INR check. Now, generally, someone who is not on warfarin, someone who is not on warfarin, the INR is between 1 to 2. Okay. Now, someone who is on warfarin, then INR value changes between 2 to 3. When someone who is on warfarin, then INR should be between 2 to 3. For metal valve replacement, the INR is little bit higher expected. Okay, 2.5 to 3.5 depends again, depending upon the condition. But still for, otherwise, for other condition, the INR should be between 2 to 3. Now, patient is coming after, 1 week. We check the INR and patient INR is still 1.9. Okay, so that is not at the target goal. So what I do is I again, bump up little bit. Dose will be increased of the warfarin. Then again, patient is advised to come back after a week. So during this, adjustment, I ask the patient not to make any extreme change in your food. So that means if you are taking salad, one ball of salad every day, so you keep doing that, no problem. There are no restriction for any salad or any type of the food. Okay, you eat whatever you are eating because your body, the patient's body, is adjusting with the dose of the warfarin as well as the diet that he is taking. Okay, so when he came after 1 week, he was every day he was taking one ball of salad, fine. After 1 week he came back and we saw the INR was 2.3. 2.3, so it is definitely between 2 to 3. So we already reached to the target goal. So now I am continuing the same dose of the medication here for the patient. Okay, now every day patient is taking one bowl of salad, fine. Salad may what will be there, green leafy vegetables will be there, and green leafy vegetables contain vitamin K. Okay, vitamin K. So he's already taking vitamin K, but with that value, the warfarin dose is being adjusted to reach to the goal of 2 to 3 INR. So now we are fine. Patient is going to take consistent type of the food that he's taking every day, and the medication dose he's going to be taking every day, same dose, same medication. All right. Now we are going to monitor the patient for the INR every 1 month or 2 months, depending upon your hospital protocol wherever you are working. Patient will be coming frequently to do that. Now, if all of a sudden, let's say patient change his diet to some kind of keto diet or something, patient decided, like I want to lose some weight. And so he joined some weight loss program. And from that program, they are advising him to eat more, green leafy vegetables, more salad, and, cutting down the carbs, sugar, all those things. One side, it is good. But now what is going to happen? As you increase the vitamin K, increasing more salad, more green leafy vegetables, now your warfarin is going to get affected and thereby INR is going to get affected. And sometimes what if patient doesn't come for the INR check, and if it is, decreased, if it is decreased because vitamin K is the antidote of warfarin, if it is less than 2, patient is at high risk of having clot. If it is more than 3, patient is at high risk of bleeding. So here, this extreme drastic change in food, in diet with vitamin K specifically is not a good idea. Okay, so our main question is client to keep consistent. Which food should the nurse instruct the client to keep consistent? That means you don't change. Whatever you are taking, keep taking it. There are no restriction. There are no restriction. I'm repeating, there are no restriction for eating vitamin K rich food. But once you are taking that, you keep taking consistently. You don't change that all of a sudden. Okay, because that affects INR. So here, which one is a green leafy vegetable? Kale is the green leafy vegetable. So others are not rich in vitamin K. Okay, so kale is a green leafy vegetable. So I already explained to you, but some of the things I all want to mention. Please, please, please do remember, no restriction, but what we advise is to take consistent amount of vitamin K. Okay, do not tell the client to completely avoid this food. Okay, so in options, if they give you option like avoid completely, that's a red flag. Okay, you try to look for the different better option. Just don't swing high or low week to week. Okay, all of a sudden you are taking too much and then completely cutting down. That doesn't work. Consistent amount you should take. What are the other examples of vitamin K rich food? So all green leafy vegetables, as I mentioned. So kale, spinach, you will see most of the time in the options. Okay, final exam. Spinach, collard green, turnip green, Swiss chard, broccoli, Brussels sprout, asparagus. Also, you will see in your options, cabbage, green tea. So green leafy is equal to vitamin K. You can remember green leafy is equal to vitamin K. Okay, so I already explained to you. Warfarin antidote is vitamin K. Another name is phytonadione. Phytonadione. Okay, all right. Next. All right. 71-year-old client with a long history of COPD, that is emphysema. So he has a long history of COPD. Is admitted with worsening dyspnea. So he already been diagnosed with COPD for many years, and now he's coming with worsening dyspnea. The client is sitting upright, leaning forward, and using accessory muscles to breathe. So basically, this is tripod positioning. Okay, so he's already sitting upright, leaning forward, using accessory muscles to breathe, and respiratory rate is 26. That means it is increased. It is increased, right? Oxygen saturation is 89. That is low on the room air. The client is anxious but alert and speaking in short phrases. Which nursing action is the priority? Okay. Now, majority of the students will be thinking that, oh, patient has short of breath. Oxygen saturation is 89%. So let's give oxygen to the patient. But actually, that is wrong. Why that is wrong? Because as per the theory point that we have discussed in the class, COPD patient is not allowed to have higher concentration of oxygen. Why is that? Because low oxygen concentration is a drive for them to breathe. Okay, if you give them higher level of or higher concentration of oxygen, their breathing drive will be suppressed. When breathing drive is suppressed, breathing slows down, more retention of carbon dioxide in the lungs. So please do remember, 1 to 2 liter is the best. Okay, 1 to 2 liter of oxygen is the best. You have to remember the theory point. 2 liter per minute oxygen is the best and good answer. Okay, practically we do use up until 3 liters per minute practically. But what I'm saying is, based on theory, you use 1 to 2 liter per minute. Sometimes if you are comparing with the other option and if you are not finding any best choice, and your option says that you give 3 liter per minute. But as I mentioned, you look for the better choice. If you're not finding out, then choosing this option is also okay. Okay, so 2 to 3 liter per minute oxygen we can give to the patient, but 4 liter is very high. So if you are giving 4 liter per minute, that means you are harming the patient most rather than the benefiting. Second important thing that I want to tell you, 89% of oxygen saturation for COPD patient is good actually. So COPD patient can have, we do have to maintain oxygen saturation between 88 to 92%. So this is okay. This range is okay for them. It is okay. It is expected. Okay, so I'm not going to give this patient 4 liter per minute for 89% of oxygen. Okay, so eliminate this completely. All right. Now look for the C option, giving albuterol. Okay, albuterol is a part of a treatment for sure. Okay, because what it is going to do, it is going to dilate the bronchi, and so the air will be easily move in and out. Oxygen can be going in, and carbon dioxide can easily come out. So bronchodilator is the best treatment. Okay, but as per our trick, what we have to do, we have to keep that option aside. First, we are going to compare with the other option, and then we are going to submit. Okay, so let's look for the D option. Provide teaching on the smoking cessation and per sleep breathing. Okay, this is also good idea. I have to teach to the patient that you have to stop smoking. And when you are breathing, you use per sleep breathing. So with per sleep breathing, what happens? The pressure is created and carbon dioxide can easily come out. That means with per sleep, what happens is back end pressure is created and that helps the trapped air to bring out. So that is helpful. So this is good idea. Now, first option, position the client in a high forward position or in tripod position. That is also good idea. So three options we are stuck with. Okay. Now you read the stem of the question one more time. What they have asked. So where is the stem of the question? Okay. Stem of the question is this. Which nursing action is the priority? So all three, these three are correct, but from these three, which one is the first priority? What you are going to do first? Okay, giving albuterol nebulizer, they are saying nebulizer. So you think about setting up with the nebulizer, taking the medication, preparing the medication, adding in that the device, and then connecting to the patient with nebulizer takes at least 1 to 2 minutes. If you're very fast to do that, but at least if you take 1 to 2 minutes to prepare that equipment and give to the patient. So if you compare between C and A, which one is the quicker? Changing position is quicker. If you change the position, lungs will have enough space and can expand better and can easily breathe the trap air out, can get, fresh oxygen in. So compared to A and C, which one is the faster? Position is faster. Okay, same thing with D. Now, providing smoking cessation. Right now, your patient is having short of breath, and you are educating the patient about smoking cessation that is going to be in the future. Right now, nothing is going to help because patient is having COPD going on for years now. So smoking cessation should be kept last because it is giving education for worsening dyspnea. Right now, giving teaching is not going to help. So now I am going to choose option first A, change position to high Fowler or tripod position, and then you prepare the patient for nebulizer. Okay, so they are asking you, okay, which one is going to be priority? So albuterol nebulizer will take time compared to changing the position of the patient. Okay, and always when patient has COPD, you think about ABCs, airway breathing come first in acute short of breath. The fastest independent intervention that improve breathing is positioning. Independent meaning you don't have to, reach out to doctor to get the order of the medication because that is also time consuming. You have to call the doctor, get the order, and then you can do it, right? But this one is easiest thing that nurse can do without any order. Best position, high Fowler tripod position. And oxygen saturation for COPD patient, please do remember 88 to 92% is the goal, not 95 to 100%. Okay. Order of action in distress. First, give position, change position to tripod or high fowler. Then you give oxygen to the patient. Then you give bronchodilator, nebulizer, whatever it is. And then reassess the patient. Okay. So first you are going to change the position, then give oxygen, then bronchodilator, and then teaching. Teaching is always last. Once patient is stable, then you are going to give teaching to the patient. All right. Next. Okay. A nurse is preparing to obtain the wound culture from a client with a chronic infected sacral pressure injury. The wound bed contains purulent exudate and surrounding slug. The provider has ordered a culture to identify the causative organisms before starting antibiotics. Okay, so what is the main thing here? The doctor has ordered the culture. So you have to take the sample for the culture to identify the causative organism before starting antibiotic. Which action should the nurse take to ensure the most accurate specimen? So you know that for taking culture sample, you have to be, like following certain, techniques to keep the sample, as viable, as accurate. Um, so what you are going to do to take the culture from this, infected wound? What you are going to do? So look at the first option. Cleanse the wound with the normal saline. Okay, you clean it with normal saline. Then rotate the swab over the clean, viable tissue in the wound bed. Clean, viable tissue in the wound bag. Wound bed. Okay. Keep this option aside. Okay. Look at the second. Swab the visible purulent drainage on the wound surface before cleansing. Swab the visible purulent drainage. Here we are taking swab from clean visible tissue. Here you are taking sample from purulent drainage. Here, C option, cleansing the wound with povidone iodine antiseptic, then swab the wound bed. Okay, this option is wrong. Why? Please do remember one principle. Culture, if you have to take, you should always take the culture sample before starting antibiotic therapy. Okay, before starting antibiotic therapy. So here you are using povidone iodine antiseptic to clean the wound bed. That is definitely going to affect the sample. So this is wrong. So you completely eliminate this option. You are not going to use any antiseptic, antibacterial, okay? Because right now we have to take the culture to find out the right bacteria, and then we can decide what antibiotic will be given to the patient. Okay, so this is definitely wrong. Look at the D option. Collect the specimen from dry, crusted eschar at the wound edge. So there is some tissue which is completely dry. Okay, and there are some scar formation, and from that hard tissue you are taking the sample. Now you know that the microorganisms always will be living on the live tissues, right? Not the dead tissue or dry crusted scar. So this also is wrong. Okay, this is also wrong. Now we are stuck between A and B. Okay, so let's read some information. We'll talk about that and then we'll come back to answer. Obtaining an accurate wound culture. Please do remember this was asked recently in the exam. So what are the steps? So clean the wound with normal saline only. So when you are taking culture, wound culture, always clean the wound with normal saline only. Never with an antiseptic. Antiseptics like povidone iodine, chlorhexidine, hydrogen peroxide can kill bacteria and ruin the culture. So we are not going to get the accurate result of it, right? So you should not use any kind of antiseptics or antibacterial. So only normal saline. Okay, step 2. Culture should always be from clean viable tissue in the wound bed. You might be wondering that as we are finding out the type of bacteria, if we take sample from purulent drainage, that will give us the best information about the bacteria. But actually, that is not right. The right information is you have to take the culture sample from clean and viable tissue, not the dead tissue. Viable tissue in the wound bed, not from pus, not from drainage, not from any slugging, and not from a scar. Remember this, okay? So this is the second principle that you have to remember. Levine technique preferred. Now, what is this Levine technique? So they are saying, okay, rotate the swab. You have to, whatever swab you are using, right? You have to rotate. You have to rotate over about 1 centimeter square of clean tissue. So wherever you are finding the clean tissue at the wound bed, you have to rotate. You have to rotate your swab at least for 5 seconds with enough pressure to express the fluid from the tissue. So what you are going to do? What is the Levine technique? Whatever swab you are using, you are going to rotate with certain pressure. Okay, you are going to rotate so that can express some fluid from the tissue, and that fluid you have to take in the sample. Okay, do not culture the surface that is having purulent drainage. There is dry crusting, scar tissue, necrotic tissue. These hold contaminants. This also holds colonizers. That means some other bacteria can be colonized, but they are not giving any infection. So you will be getting information about those bacteria which are not causing the problem. Okay, so you want the information about the bacteria, they are causing the problem, they are causing the infection, so that you can choose the right antibiotic for those bacteria. But if you are using the sample from the pus, from other like contaminants, then some colonized bacteria can also show up in your culture report, and that is not much helpful. Okay, now sterile technique throughout you have to follow. Use a new sterile swab, label and transport promptly to the lab. That means you cannot just allow that sample to be, sitting there. You have to send it to the lab as soon as possible. Timing, obtain the culture before the first dose of antibiotic whenever possible, so results aren't skewed. That means accurate result will be getting. White matters and accurate culture identifier the real causative organism. Because of that, correct antibiotic will be given to the patient, and so there will be effective treatment. And contaminated specimen lead to the wrong therapy. So we don't want to do that. So memory trick is only saline, no antiseptic, only clean tissue, no pus, no pus. Okay. All right. So coming back to here, what would be the correct answer here? The correct answer is A. Clean with normal saline, then rotate the swab over the clean viable tissue in the wound bed. Next. Okay. The nurse who normally works on the psychiatric unit is floated to the busy medical surgical unit. The charge nurse is assigning clients. Which client is most appropriate to assign to the float nurse? The nurse who normally works on the psychiatric unit. Okay, so what is going on here? The psychiatric unit nurse is being floated to the medical surgical unit. The charge nurse is assigning the clients. Which client is most appropriate to assign to the float nurse? As per our strategy class, what is the principle for the float nurse? Float nurse who is someone who is transferring from her main department to the different department because of the staff, deficiency. They do not have enough staff, so one nurse is transferring from her original main department to somewhere else. Now you think about yourself. If you are working in the psychiatric unit every day, so you are so used to with your patient, you are so used to with the treatment, you are so used to with the expected outcome, complications, emergencies, whatever it is, but you are aware about that thing, right? Now all of a sudden, if you are transferred to the medical surgical unit, you are not going to know the complexity of those conditions, right? Even if you are a registered nurse, but it is difficult for us to manage some unexpected things what we are not used to with. So the principle is that whenever any float nurse who is coming to our ward, our unit, that nurse is new for us. That nurse, this whole unit is new for her, right? So principle is we have to give only stable patient to her. We have to assign only most stable patient to her so she can help us without any risk to the patient and liability to her. So only stable patient we are going to give her. That is the principle of the float nurse assignment of the patient. Okay, so what they are asking, which patient is most appropriate for the float nurse who is transferred from psychiatric unit to the medical surgical unit. Okay, so look at the first option here. A client with a stable heart failure awaiting discharge who needs routine oral medication and reinforcement of the dietary teaching. Okay, so here it requires dietary teaching. So that means as a registered nurse, even if she's from psychiatric unit, but she knows what diet should be given to the patient, right? With someone who has a heart failure, cardiac diet. And so she has to reinforce the education and she has to teach about the oral medication that is prescribed from the doctor. So she's going to review the medication with the patient. She's going to educate to the patient that, okay, these are the medication that you have to take in the morning, afternoon, evening time, and these are the diet that you are going to follow. Okay, so this is giving education. Okay, nothing else is needed here, right? I'm going to keep this option aside. Look at the second option, B. A client 2 hours post-operative from thyroidectomy. Guys, someone who has undergone the surgery, that patient is critical up until 12 hours. From 12 hours to 24 hours, you still need to supervise the patient, you still need to monitor the patient, but with little bit decreased risk, but still there is a risk. Okay, we don't know what are the expected, we don't know like what is going to happen with the patient. And when we talk about thyroidectomy from medical surgical, so many things we have to monitor. We have to check for the bleeding, we have to check for the airway, we have to check for the hypocalcemia signs and symptoms, reflexes, so many things we have to monitor after thyroidectomy, right? Hormonal things and many things. So this patient is just the 2 hours after surgery. Definitely, this patient requires more attention. And for new nurse, this patient is not going to be that easy, right? This patient definitely not stable patient. So we are not going to assign her this patient for sure. Okay, look at the C option. A client receiving their first unit of packed RBC for symptomatic anemia. Their first unit of RBC. Okay, when we give any blood unit to any patient, first 15 minutes is very critical. Okay, you have to monitor the patient for all different unexpected complications, like if patient is developing any fever, patient is having any chills, patient is having any chest pain, patient vital signs are normal or not, patient is developing any allergic reaction or not. All these things you have to monitor the patient for first 15 minutes. This patient is having anemia, plus patient is symptomatic. Now, symptomatic meaning patient heart might be triggered with anemia. Palpitation can be there, tachycardia can be there. So patient is already experiencing some symptoms from anemia, and patient is going to be receiving the RBC for the first time. When first time RBC is given, definitely we don't have any history of past, if there is any complication was there in the past or not. So it requires more attention. But if you compare between A and C, that someone who is starting RBC infusion for the first time and one patient is just getting discharged, is stable, just need education. Which one is easy? A option is easy. So I'm still going to remove this in compared to A. Look at the D. Client newly admitted patient always need more, you know, assessment, like head to toe assessment should be done. You have to diagnose the patient, right? What is going on? So newly admitted patient plus chest pain and troponin level is pending. So that means we don't know patient is experiencing myocardial infarction, patient is experiencing angina, or patient just have the muscles kind of pain. We don't know what is going on, so that requires more attention to that patient, right? And as depending upon the results that we are going to get, we have to initiate some protocols like myocardial infarction protocol, angina protocol, whatever it is. But so many things will be done for that patient. So definitely not this patient compared to A. Correct answer is A. Okay, so some information about the delegation and float nurse assignment. Golden rule is assign the float nurse, that is less specialized nurse, the most stable patient and the most predictable patient we are going to give. Okay, keep unstable, complex and specialized client with the experienced unit staff. You cannot give this patient to new nurse who is coming to your unit for the first time. The float nurse or any RN outside their specialty. Okay, one nurse can be special, a very experienced in the emergency room, but she might not be knowing what to be done in medical surgical unit. She might be experienced in ICU, but she might not be experienced with psychiatric unit, right? So any nurse who is being floated always be assigned stable patient. And what kind of things that you can assign to them? For example, they can handle safely. What are they? So stable vital signs. When someone, so any patient who has stable vital signs, you can assign that patient to her. Someone requires only oral medication, right? Basic assessment, not the complicated assessment, basic assessment. Maybe patient is already diagnosed, it's just the follow-up assessment that you are doing. Activity of daily living, and discharge teaching reinforcement, all these things you can assign to float nurse. Do not assign the float nurse about fresh post-op patient, like first 24 hours. Do not assign, because first 24 hours are critical for the patient, especially first few hours. As I mentioned, 12 hours are more critical than 24 hours, but within 24 hours the risk is just the decrease, but it's not completely gone. Okay, so first 24-hour post-op patient you should keep aside for highly experienced nurses. Client starting blood transfusion, don't give, because as I mentioned, first 15 minutes more critical. Unstable critical client, those needing specialized equipment or judgment. Okay, so for example, we had one patient whose troponin level was pending, and depending upon the results of troponin, we have to decide what would be the treatment. So that is going to be new for this nurse. Most stable patient, most appropriate for the follow nurse. Most unstable, keep with experienced staff. Watch for the trap. Okay, in the exam they will use some distractor. What are the distractor? So they will give you like big conditions. Okay, for example, they will say, oh, patient is having heart failure, patient is having COPD, diabetes, but sometimes those patients are stable. Why? Because that is been going on for years now. Patient was diagnosed with a heart failure few years ago, but patient is stable right now. Patient was diagnosed with a COPD few years ago, but right now patient is stable. Okay, patient is okay. So stable patient or patient who are near discharge is safer than acute and immediate post-op. So immediate problem, acute problem are requiring more attention to, and chronic problems, stable patient does not require any more attention. So just little bit reinforcement with assessment, education. So those patients you can give to float nurse. Okay. So we know the principle of assignment, that should be right task, right circumstances, right person, right direction, and right communication, right supervision. Okay, these are the principles of delegation. Next. Okay, this is straightforward question, but sometimes students make a mistake here. A client is brought to the emergency department with an acute asthma attack. Patient is here in emergency department with acute asthma attack. The client has audible wheezing. So wheezing is there. He's using accessory muscles. He can only speak 2 or 3 words between breath. That means he is having short of breath. When you are, have to catch breath when you are having short of breath, you will not be able to finish the whole. I want, so in between, there will be few words will be or few phrases, but they will not be able to complete the full sentences. That means they have hard time breathing and speaking together. Okay, which medication should the nurse anticipate administering first? So, okay, albuterol, mm, for sure you are thinking of, but always compare with other option because some of the students make mistake here. If you can see all the options, these all options are a part of treatment for asthma. Okay, is a part of treatment of asthma. So all options are correct. But what is the stem of the question? They used one strategic word here. First, which one you are going to give first? Okay, whether you are going to give albuterol first, ipratropium, methylprednisolone, which one you are going to give first? So see, albuterol, how it works, it is bronchodilator. So it is going to dilate the bronchi. So patient will have easy breathing. What is wheezing sound? How the wheezing sound is produced? So this is the bronchi. And if there is inflammation going on, with inflammation, there is narrowing of the airway and air is moving in and out with lot of pressure, with lot of friction. So when the air is moving with the friction, it produced one sound that is called wheezing sound. Okay, so here if you are giving albuterol at first place, it is going to dilate the bronchi and patient can breathe easily. So this can be correct. Okay, now what is the purpose of the ipratropium? Ipratropium is going to decrease lot of secretions and it is going to keep the alveoli open because one of the function of it is smooth muscle relaxation. Okay, so ipratropium works for two things: decreasing secretion from inflammation, and second thing is it is going to keep the bronchi open. It will prevent the bronchoconstriction. So that is also a good option. Okay, methylprednisolone. Methylprednisolone is going to decrease the inflammation. All this inflammation that is present here, it is going to decrease the inflammation. So that medication also we need. Montelukast. Now, montelukast is not for the acute asthma attack. It does not help with acute asthma attack. It does help in prevention of asthma attack. Okay, that is for the prophylaxis, specifically related to allergy. Okay, so some patients will have asthma related to allergies. So those patients will be put on this montelukast. Okay, and this montelukast does not help with acute episodes. It does help only with prevention of asthma episode. So eliminate completely. Okay, you are not going to look at this D option because our strategic word is first treatment. What you are going to do? Okay, what if I'm giving this patient methylprednisolone that is going to treat the inflammation? It is going to take time to treat the inflammation, right? But bronchi are still constricted. Patient has hard time breathing. So if you give priority to ABC, if you follow this priority, airway, breathing are the important one here, right? So methylprednisolone helps with only inflammation, but it does not help with dilatation of the bronchi. So I think the albuterol is going to work better in acute episode, and that is also called as rescue medication, right? So when you give that, what will happen? Bronchi will be dilated sooner, Okay. And then second, for the maintenance, you can use ipratropium bromide and prednisolone, but they are not much helpful in, kind of acute and severe short of breath. Sometimes in the hospital, if patient has, mild dyspnea, short of breath, we do use ipratropium bromide nebulizer for the patient, but that is for the stable patient. Someone who is having wheezing present and acute episode is going on, they are also using accessory muscles, then you need something, quick relief medication, rescue medication, that is albuterol is going to dilate the bronchi within few minutes, and patient will be able to breathe better. And for the maintenance purpose, you can give ipratropium and methyl prednisolone. Okay, next. Okay, a client with the AIDS telephoned the clinic to report that their roommate was just diagnosed with the shingles. Okay, patient who is having AIDS diagnosis, that means definitely he is in immunocompromised state, because HIV is the infection, but AIDS is the last stage of HIV infection, right? It's very bad immunocompromised state. So patient is having AIDS, he is telephoning the clinic, okay, and reporting that his roommate is diagnosed with the shingles, herpes zoster. The client states, I already had chickenpox when I was a little, so I should be fine, right? He's asking that I had chickenpox when I was a child, so will I be okay? Will I be fine? Which response by the nurse is most appropriate? Before we look into options, think about the theory points. So, shingle is the reactivation of varicella virus. Okay, so someone who had chickenpox in the childhood, that means they are already immune. On top of that, they might have taken vaccine. Okay, but at least getting chickenpox in the childhood itself gives immunity to the patient. Then you don't get the chickenpox. Like, it's very rare that you get. I mean, I would say if someone who has got the chickenpox in their childhood, they are not going to get chickenpox again. But when their immunity goes down, specifically with older people, or specifically with HIV/AIDS patient, or someone who is having chemotherapy drugs, like chemotherapy going on, someone who has undergone any transplantation, grafting, all these patients who have immunocompromised state, what happens is this virus who were in their dormant state, they get activated, because now hosts do not have enough immunity to fight against this virus. They get activated and they give disease. So someone who had chickenpox in their childhood cannot get chickenpox again, but they can get shingles again if their immunity is poor. But another point, if someone who has shingles and another person who never had, chickenpox in their life, there is a chance that they may get chickenpox. Okay, remember that. So here your patient is immunocompromised. So what is the correct information? What you should tell to the patient? Okay, so look at the first D option. D. Go directly to the emergency department and request the immediate isolation. Okay, that is not required here because patient is already immune. Okay, right now, even if the patient immunity is down, but immunity towards the chickenpox, towards the shingles, patient is immune, right? So there is no need of going to the emergency department right now and requesting immediate isolation. Look at the C. Since you had chickenpox as a child, you are immune. Correct. You are immune. Correct. And don't need to do anything else. But guys, patient is immunocompromised. We don't know this patient is going to get shingles or not because of his immunocompromised state. So you cannot just assume that you are immune and do not need to do anything. Definitely, we have to give education to the patient about this, right? We have to teach him about the signs and symptoms of what can happen, what are the, outcomes, complications. We have to educate to the patient. So you can keep this option aside, but still we can look for the better option. If you don't find any better option, then you can pick this one. Okay, no problem. Look at the B. Come to the clinic today so we can give you the varicella vaccine. Guys, varicella vaccine is a live vaccine. And live vaccine you cannot give to someone who is in immunocompromised state. So this is straightforward wrong. Your patient is having AIDS, you cannot give varicella vaccine to him. Okay, now come to the A point. Please come in so we can evaluate you for the post-exposure prophylaxis. Okay, that means patient is already exposed to this virus because roommate is having this. So nurse, what she's saying, you just come in. We want to evaluate you for the post-exposure prophylaxis such as varicella zoster, immune globulin or antiviral medication. If patient is a candidate for varicella zoster immunoglobulin, because why immunoglobulin we are talking about? Because someone who has poor immunity, then we need to give them some extra support for the immunity. Okay, so there are some options available that after exposure, specifically for the immunocompromised people, we need to evaluate because the risk is higher. So if I compare between A and C, they both are correct. They both are correct. Okay, patient had chickenpox in the childhood, so he's immune. He doesn't have to do anything unless he develops some signs and symptoms. But at the same time, patient is very badly immunocompromised, so we cannot just let the patient, go like that. Okay, okay, you are fine because you are immune. You had chickenpox, you are immune, you are fine. We cannot just do that. We have to evaluate the patient. We do have some options available that after getting exposed to prevent further, recurrence of these shingles, what need to be done? Because patient cannot get chickenpox again, but patient may develop shingles if patient's immunity is poor. So first option, A option is better choice. Okay, let's read some information here. Immunocompromised client like AIDS, chemotherapy, transplant, high dose steroid cannot rely on prior immunity. These patients cannot rely on prior immunity. Remember that. A past infection or old vaccination may not protect them. It's not necessary that that protection from the childhood will be carried forward in their immunocompromised state also. Not guaranteed. Exposure to chickenpox or shingle is a risk. Herpes zoster lesions can transmit the varicella zoster virus to the susceptible immunocompromised person. Post-exposure action will be evaluating the patient for the prophylaxis. Right now, patient did not get any shingles right now, but we do have some prophylaxis options available. Okay. So we can evaluate the patient for prophylaxis, then varicella zoster immunoglobulin and or antiviral such as acyclovir, valacyclovir should be given to the patient as soon as possible after exposure because patient's immunity is low. Okay, for other patient who do not have that problem, they are fine. We don't have to give them any prophylaxis. Okay, that time we can say, okay, okay, you are immune. You had chickenpox in the childhood, you are immune, so no need to do anything. That is correct. But someone who has immunocompromised state, we cannot let them go like this. Okay. Also, live vaccines are contraindicated, specifically varicella, MMR, rotavirus, intranasal flu, yellow fever. So never give the vaccine, varicella vaccine to the client with the AIDS. Right? Never dismiss an exposure with you are probably immune. So you cannot use this sentence for immunocompromised patient. That's the wrong answer. And reduce the exposure risk, that is immunocompromised clients should avoid contact with anyone who has active chickenpox or shingles. So we need to avoid them. Okay, we need to avoid the exposure. If you know that someone who is infected with that, you cannot just go and see them. 69-year-old client with 30-year history of COPD. How many years of COPD? 30 years. So 69-year-old client with a 30-year of history of COPD is admitted with worsening dyspnea and fatigue over the past 10 days. How many days he is having that short of breath? Worsening short of breath. That means he has COPD for 30 years. For 30 years, he's surviving, right, without any problem. I mean, problem is there, but everything is kind of stable. But what is going on? Whatever short of breath, fatigue, tiredness he had on top of that since last 10 days, that is worsening. Dyspnea, worsening. Fatigue is worsened for last 10 days. So on assessment, the nurse notes that distended jugular vein, enlarged tender liver, plus 3 pitting edema in both the ankles and 5-pound weight gain over past week. Lung sounds are diminished with scattered wheezing, and the client reports needing 3 pillow to sleep. Oxygen saturation is 87% on 2-liter nasal cannula. ABG result is given. pH is 7.41. Okay, so let's interpret this. So pH, normal pH is 7.35 to 7.45. So patient is within this range, 7.41. Carbon dioxide value is 35 to 45, slightly elevated, but that can be present because of the COPD, because COPD patient will have retention of the carbon dioxide. Bicarbonate 25, so 22 to 28 bicarbonate, so that is normal here. So if we look at the ABG analysis, it is kind of okay. There is nothing like imbalance is not going on. Okay. So which condition should the nurse suspect? Which condition nurse should suspect? Okay. Now, whenever, so if you recall the theory points, okay, theory points. So we did talked about right-sided heart failure and left-sided heart failure in cardiovascular system. So what we had remember, right-sided heart failure, you have to remember rest of the body, okay, and left-sided heart failure, you have to remember lungs-related symptoms, okay. So this patient has a scattered wheezing, but if there is a left-sided heart failure, the patient will have crackles present. Patient will have frothy, blood-tinged sputum present, can be present. So here, left-sided heart failure se zyada to right-sided heart failure ke symptoms are more, right? So you see here there is tender enlarged liver, that means hepatomegaly, jugular vein distension, pitting edema is present, weight gain is present, and patient is also using more than one pillow at night time to sleep. So paroxysmal nocturnal dyspnea. This patient might be going on some heart failure. Okay, now heart failure is there. Okay, look at this one. Compensated respiratory acidosis. Compensated respiratory acidosis. No acid-base imbalance is going on. We can completely eliminate this option. Acute respiratory distress syndrome can be present. Left-sided heart failure. We can consider only few symptoms, like there is short of breath, there is a weight gain. We can consider that, but other symptoms that they have given, jugular venous distension, right-sided jugular venous distension, hepatomegaly, pitting edema, they are more of right-sided heart failure, right-sided. So I'm going to eliminate this. Now I'm stuck between B and C, acute respiratory distress syndrome and core pulmonal. Now, let me explain to you. Core pulmonal. What is core pulmonal? That you need to understand. Core pulmonal is a right-sided heart failure because of any chronic lung condition. Okay, so we have separately discussed right-sided heart failure and left-sided heart failure. But right-sided heart failure, if it is because of any lung problem, chronic lung issue, then it is called core pulmonal. Core pulmonal. What happens here when we talk about right-sided heart failure? Okay, give me 1 second. For example, this is the heart. And if you can know, this is pulmonary artery that brings the blood to the lungs for the purification process. Okay, that brings the blood to the lungs for the purification process. Now in the lungs, what is going on in the lungs? In the lungs there is COPD for 30 years, and this lung has all this scar tissue present. The alveoli are dilated. There is chronic inflammation is going on. So this pulmonary artery has hard time, sending the blood to the lungs, because there is lot of resistance present in the lungs. Because of there is lot of resistance present, there is a backflow of the blood, and then blood is coming back here in the right ventricle. Now over the time, because of this chronic condition, what is going on? The right side ventricle will have hypertrophy, because to accommodate this extra amount of the blood that is coming from the lungs, that is a backflow. So it is coming from the lung, because of the higher resistance, it is getting collected here, there is a hypertrophy, and over the time this ventricle, right ventricle, fails to pump the blood. Now when it fails to pump the blood, what will happen? This blood will come back here in the right atrium. In the right atrium we do have two openings, superior vena cava, inferior vena cava. Through superior vena cava, blood will go to the upper part of the body. Through inferior vena cava, blood will go to the lower part of the body. That give rise to the weight gain, edema, jugular venous distension, blood pressure will be higher, hepatomegaly will be there, splenomegaly will be there. So all these symptoms are related to right-sided heart failure, but that occurred because of COPD. So now our correct answer is going to be cor pulmonale. Okay. So cor pulmonale is a right-sided heart failure from lung disease. Lung disease. And you will see the signs and symptoms are similar to right-sided heart failure. Okay, similar to right-sided heart failure. So your patient, in COPD patient, new peripheral edema developed. That means he did not have any peripheral edema. New edema for last 2 or 3 days. Jugular venous distension is present. Hepatomegaly, weight gain. That is suspiciousness for cor pulmonale. Okay. Okay. So client with the cystic fibrosis is being taught controlled coughing to help clear thick secretions from the airway. Which statement by the client indicates the correct understanding of the technique? So this is a chronic problem for the patient, and every day he needs to learn. I mean, every day he needs to, remove all the secretions as much as he can try, right? But so proper technique, if we teach to the patient, it will be very easy for him to expectorate all the secretions out. So what you are going to teach to the patient? Look at the D option. I will breathe out completely first. So he's going to exhale first and then cough forcefully at the end of the each breath. Okay, so he's going to completely breathe out everything first and then he's going to cough. But remember, when you exhale completely out, when you don't have anything remain inside, how you're going to be coughing with each end of the breath? That means during exhalation. So that is not the proper technique. Okay, I will lie flat. Oh, lying flat is not going to help to remove all the secretions out. Okay, that is wrong. So coughing, sleeping, lying down, supine position, and then coughing to remove all the secretions out, it's not the effective technique. I will take several quick, shallow breath. Okay, then cough as hard as at I can all at once. Okay, to some extent, it can be correct. Okay, look at the first option. I will sit upright. Okay, proper position. Taking slow breath. Fine. In through my nose. Hold it for a couple of seconds and then cough twice using my abdominal muscles. This is perfect. Do you remember the huff technique, huff coughing technique? In that, we were teaching the patient to deep breathe in and out, 2 to 3 times. And then after 3 or 4 breaths, when patient is giving us, like patient is coughing, he has to cough from the deep of all these abdominal muscles. And he has to use those muscles and he has to cough up all the secretions out. That huff technique. So first deep in and out breath, and then deeply he has to cough out all the secretions. That is basically they are asking you about the huff technique. Okay, so what is the best one? Taking slow deep breath through the nose and then hold it for a couple of seconds and then cough twice using abdominal muscle. So that is a correct technique. Let's read about it. Okay, this is about the answers. Read here. Control curve steps, because they have asked us about the controlled technique. Okay, so sitting upright, leaning slightly forward, taking slow deep breath in through nose, hold it for 2 to 3 seconds, and then coughing 2 to 3 times using the abdominal muscles, then rest, and then again repeat. This is a better technique. Position also matters. Always upright and leaning forward does help with the maximizing lung expansion. Sleeping position, lying flat doesn't help. Okay, so never teach coughing while lying flat. Deep breath first. Air must get below the secretion, because the secretions which are pushed out, that is by force of the air that you are inhaling. So if you are exhaling all the air out and then if you try to cough out, there will not be proper force exerted. So first you have to deep breathe in so the air goes beyond the secretions, and then when you are coughing out, the air can push all the secretions out. Half coughing for fragile airways like COPD, emphysema. Take the medium to deep breath, then exhale in short, forceful bursts like like that. So that is called half technique. Okay. So half technique or ha technique, it can be called as. So that technique can be used in COPD and emphysema patient. Like those patients are very fragile. We don't want any bone problems there, like fractures and other problems. We don't want that. So easily patient, and also we have to conserve the energy and oxygen in this patient. So short huffing technique does help. Here they had asked us about the controlled technique. So that is with deep breath in, holding it for a few seconds, and then puffing out 2 to 3 times. So, timing tips: cough after bronchodilator and nebulizer and after chest physiotherapy. That is the best time. Encourage the fluid to thin out all the secretion. These are the extra, interventions that always you can encourage the patient to do. That does help with, thinning out the secretion and removal. Support incision if patient is post-op. So if you are encouraging the patient to do this deep breathing and coughing exercise, what can happen? They can have, suture separation. Okay, evisceration lesions can occur specifically after abdominal surgery, so we don't want that. So you need to advise the patient to use use some splinting technique. They have to hold the incision in place with pillow, with their hands, with their arms, and then patient is taught to um, cough. Okay, so this is about the controlled technique of coughing out and clearing all the secretions.